Hi, everybody. I am Daniel Yaeger. I teach at New York College of Pediatric Medicine in the Department of Surgery. The topic is the Keller arthroplasty for HIPJ ulcerations. I have no financial disclosures. The Keller bunionectomy was originally described in 1904. Um, Originally, it was described by Davis Cooley's in 1887. It was popularized by Keller. Now, the reason why Keller did this was because prior to the Keller bunionectomy, he was standard of care for bunions procedures were metatarsal head resections or a cystectomy, or what we would call the silver McBride nowadays. And you'll see a a sawbones model on the next slide. It's very aggressive. So originally described in 1904, popularized in 1904, and then in 1912 he presented the results of 26 patients. He says that 24 of those 26 had excellent functional results. Now, it's crazy to think now that he did this on patients that were in the army. If you took a young, healthy patient and performed a Keller bunionectomy on them, you'd probably lose your license to practice, but then it was considered standard of care, or it was considered, normative. Okay. And it was, again, better than the alternative, which was a med head resection. Um, in the actual paper, he gets a lot of frack. We talk about this every time we discuss Kellers during our grand rounds at the college, is that Keller confused the flexor hallucis brevis and the flexor hallucis longus. In his paper, when he's describing it, he talks about how he inserted a drain between the metatarsal head and the proximal phalanx for 48 hours. It doesn't say why he did that, but it says that he does. And then he resected the base with either a rongeur or a jiggly saw. Um, Nowadays, we use sagittal saws, so it's just like funny to think that this is how it was done. And just to provide some historical significance to this thing, the McBride bunionectomy wasn't described until 1928. So it's kind of just important to like realize like where this is coming from. And this is his original paper. Okay, Keller himself was a general surgeon. I mean, you can see how much they took off over here versus this side. And this is one of the patients that he did it on, and you can see how long the big toe is over here, and how in the post-op that's how short it is. I think what everybody notices what happened here? It's is this like a med section? Like, was this what they were doing? Because over here, the med head, they staked it a little bit, but it's reasonable. This is obviously very aggressive. Now, this paper was written in conjunction with Dr. Jules, one of my mentors, and a group out of Spain. And what the goal of this was to discuss, how big is the tendon insertion at the base of the proximal phalanx, and how much of the proximal phalanx can you resect before you destabilize it. So they looked at the medial and lateral flexor hallucis brevis, the extensor hallucis brevis, and they're trying to figure out again like how much is safe. And the resection margins should not exceed greater than 3 millimeters. That's the number that they came up with. Now, this is what happens when you remove excessive bone. This is not one of my patients. This patient was referred to me for a revision. Keller was done, and Keller had been performed, and you can see the result of this. I mean, this is not good. This is what happens when you take out too much bone. This is a patient. Again, this is not something I did. This was a patient who I saw for something completely different. And I noticed this, and I just thought it was really interesting. This is what happens down the line. Now, again, this is when they resected way, way, way too much bone for this. And this is what a lot of the Kellers end up looking like down the line, is because if you don't have that anatomic space between them, the base of the proximal sinus kind of cups into the med head that way. For some reason, though, these patients are asymptomatic. I have not seen a patient symptomatic from this. All right. This is the first Keller that I did as an attending for a bunion. Patient was 80 years old, relatively healthy. But I mean, you can see like, pretty osteoporotic. And this was my end result. This is what I started with, and this was my end result. Patient did well, relatively simple, and all it involves is a K-wire. So this is the first one I did. Patient did relatively well. So I started utilizing it more. for some of my older patients. This patient was in her late 70s, and I was feeling inventive that day, so I tried using, I did a 2K wire Keller. One's a 6.2 and one's a 4.5 to hold it a little better. This is one of my happiest patients. This patient is 60, but she was medically complicated. She had COPD, she had HIV, so I wanted to do something nice and simple. This patient I had seen for a bunion. This was a hallux rigidus, and again, this patient, not the happiest, but this patient is thrilled with this, and she's not scheduled yet for her other side, but she's considering it. Now, there seems to be this love-hate relationship with Kellers. From a technical standpoint, they're super simple. It's good for deformity correction. It will provide pain relief. Supposedly, you maintain a functional range of motion. This patient who had it would disagree. If you read this, most patients are satisfied with the expanded range of footwear. I mean, okay, I still pay, regardless of the kind of bunion I do, I tell patients afterward that they have to be reasonable with that. Now, the problem with these is, as we all know, the transfer metatarsalgia or transfer lesions, limitation, flexion, recurrence of deformity, and development of hammer toe deformity at the second or at the first if you take off too much, and possible stress fractures of the lesser mets. Now, the same reason why Kellers are not the greatest procedure for bunions is the same rationale why they're so good for HIPJ ulcerations. You look at these, a lot of these end up being slightly dorsiflexed over time. And the reason for that is because if you resect aggressively, you end up detaching the flexors, and you end up with like a little bit of a floppy toe, which is a problem if you're doing this for a bunion and you want like a nice result. But if you're doing this for an ulcer and you want to offload the HIPJ, that's perfectly acceptable, or it's acceptable. So these are all the different papers that I've found where people have described it. This is from McGlamory's. This is Dr. Steinberg's and Paul Kim's chapter. And this was my first time reading about this. I'm reading through this chapter and I go, the Keller. Okay, I mean, I guess that makes sense. I started speaking to people about it. We really weren't doing a whole lot at the college when I started, but I'm going to show you some of these numbers for these HIPJ ulcers, and you really start thinking to yourself, like, should we be doing more of them? The hallux ulcers is one of the most common types of ulcers in the feet. It accounts for approximately 30% of all diabetic foot ulcers. And when I saw this statistic, I started thinking back to my population, and I go, you know what, that makes kind of sense. And then when you think about the biomechanics of why, it makes even more sense. You think about how many patients you see that have hallux limitus, and then all you got to do is add in a little bit of diabetes and some neuropathy, and you can kind of start seeing like why that would be a thing. Like think about how many patients you see, that have that painful pinch callus, and then add a little bit of neuropathy, and instead of being a painful pinch callus, you now have an ulcer. So think about all the patients you see that have a structural hallux limitus or a functional hallux limitus, and then it also kind of makes sense because a lot of my patients, they'll have this pinch callus there, and then the pinch callus will ulcerate. So you put them in a surgical shoe, callus gets better, ulcer gets better, ulcer heals. Then they go back into sneakers. Lo and behold, ulcer occurs. And that kind of makes sense when you think about the biomechanics and the causal pathway to this ulcer. So that's kind of how I got into doing these Kellers. Now, again, these are all from different papers that, these are not my cases, all different papers I've read. And they show, look, some of these ulcers look really, really horrible. And you see that they did fairly well. Now, some of them shortened up a lot. Like if you look at this one, it's pretty short. But at the end of the day, it's limb salvage. You're trying to save the toe. So, is a short toe really the end of the world? In man's foot and ankle surgery, They recommend 6 months of conservative therapy prior to performing the Keller arthroplasty. Here's my problem with that. How long do you have to have this wound open for before you're concerning for osteo? So, you really like to get to this before the patients develop osteo. So I think 6 months of conservative therapy for this is excessive. Um, but those are again the recommendations. Now, again, I don't know that I necessarily agree with that, and probably for a large number of my patients that I'm going to be showing soon when I show the cases, have have had these ulcers for, I think some of them have had it for 4 or 5 years. So at the point that I'm seeing them, it's almost like they've been there, they've done that. It's time to do something about it. The other issue is that the Keller does not address osteo of the HIPJ. So for that, you're going to have to either do a hallux arthroplasty or as I'll show, I've done bone biopsies on some of them. The other thing is, can you do a Keller and an HIPJ arthroplasty? The problem is that you're going to shorten down the toe significantly. But if you have osteo with the HIPJ, you kind of need that because, again, the Keller's not really doing much. Now, there's a lot of good, literature out there saying that you can treat forefoot osteo with oral antibiotics alone, or if you're doing oral antibiotics in conjunction with some bone debridement, that could work. So that's something to keep in mind. So here are some of my cases. This is the first Keller I did. This is a lady who's had this ulcer for going on 5-6 years at the point that I saw her. So this is what she came in looking like that first visit. We discussed amputation of the hallux after getting the MRI. Obviously, the MRI came back positive. This has been there basically forever. She didn't want an amputation of the hallux. And quite frankly, it looks chronic. It's swollen, but is it acutely infected? Is it making her sick? Is she septic? No. So there's no real reason to rush into an amputation from this if there's a possibility of salvage. So I started off with a hallux arthroplasty. And because this had been there for so long, I took out the HIPJ and performed the arthroplasty, put in a cement spacer, and put in this, this mini rail on the side. The problem with these is the patients really can't walk on this. Even if they could, I'm really not comfortable with allowing them to walk on this. So she stayed off of this thing. She was compliant. Take off the mini rail in clinic, and lo and behold, the cement spacer in there starts backing out, and now it's causing a pressure lesion. So go back in, take out the cement spacer, put in a pin, bone biopsy it again, and I get a negative result. Okay, so we're now moving along. It's been 4 or 5 months since I had initially treated her, and the ulcer recurs. So now it's time I perform the Keller on her. And this is what she looks like. So this is what we started with, and this is 1 year post-op. So the patient's doing great. Patient's doing great. Patient loves me. Always come in a clinic every couple of months, following up, talking about how I saved her toe, talking about how I saved her foot. Everybody else would have just amped it. And then ulcer recurs. What these patients don't seem to get is that once this is healed, this is, I almost started thinking about these ulcers as being in remission as opposed to healing, where they can always come back. They still need to wear proper shoe gear. They still need to routine follow-up, So again, I have no intention to reoperate on this patient. Right now, I'm just doing with local wound care and going to talk to her again about, using the orthotics, good supportive shoe gear, and we could avoid further surgery. This is another one. This is a patient who was admitted to the hospital. We were consulted when she got admitted. As you can see over here, the hallux is red, hot, swollen. This is already after a couple of days of antibiotics when I saw her on the floor. What's not good is that this tissue looks gray, and this looks terrible. Now, this is not the classic area that you think of as like, pinch callus and the ulcers happening because of hallux limitus. That's more like a pinch callus, should be like more like over here, the medial aspect of the HIPJ. But at the end of the day, you want to be able to offload this, and if it should work if you're able to adequately dorsiflex this. And the patient has a bunion, so you can make the argument that she has that functional hallux limitus. So on this one, I did the Keller, did not take off the full 3 millimeters. because I didn't want to excessively shorten it. And I also performed the HIPJ arthroplasty. Now, look at my incision. This is not an incision I like. It's not an incision I recommend. I don't when I have to do these now, I try to avoid doing that the lazy S over the HIPJ. I try to just do a straight linear incision. This was her as she was healing. We also got her revascularized because obviously you look at that like gray tissue in there. She can't have too much blood flow going to her foot. So had our vascular guy, my vascular interventionalist, do his intervention as well. And this is her a year post-operatively. So again, she went to fully heal. Now, again, so just something to note is look at the way that the hallux is dorsiflexed and the hallux is somewhat hammered. Okay. If this was a regular bunion, I would not be happy with this result. Okay. But it's not. Anybody else probably would have looked at this and said, all right, there's osteo, let's amputate it. But I just don't think it's indicated if you can, give her a result that looks like this and she still has her toe left. I mean, if you can salvage it, why not? This is one of my favorite cases. This was a patient, again, she's 80 years old, healthy patient. She's got some, a touch of dementia, shall we say. So this is how she shows up for the first clinic visit. She went to the ER for this, started on antibiotics, and she came to clinic. She was referred to the clinic. Again, this is not, super infected. So took her in, did the Keller on her, tolerated it well. She's 80 years old. And this was her and this is her every week, every 2 weeks as she's healing in. And you can see that, she healed relatively well, relatively quickly. This is her post-operatively. And she's remained ulcer-free and she's ambulating. But one of my favorite slides to show is this. I love this. Industry has created all these fancy ways of managing bunions and, MIS bunions now with, 2 screws put in percutaneously and lappy this and lappy that. When this is the quality of the bone that you're managing, it becomes very, very, very hard. I have a hard time believing that any kind of hardware is really going to get adequate bite in this, which is why 120 years after Keller, first popularized the Keller, it's still being talked about because when your bone quality, when this is the quality of the bone that you're working through, I know industry wants us to, start doing all these fancy bunions and stuff, but I don't know what kind of hardware exactly you're going to be putting through that'll achieve some bite. This is another one of my patients who's had this HIPJ ulcer for approximately 5 years. Again, she was offered an amputation. She had been growing out MRSA. She was previously talked, general surgery had seen her. They talked to her about an amputation. At some point, she had some sort of debridement on this thing. So again, she was just happy, like, okay, so, talk to her about the Keller. And obviously she agreed because it sounded better than an amputation. This picture looks crazy, but this is her a couple of weeks after that. She wanted to fully heal. Again, the toe is dorsiflexed because, slightly more aggressive resection than I'd like to do. But she went out to fully heal. She still has her toe. So this is another happy patient. Now, complications. Kellers themselves have complications. You've already seen some of them. In addition to all that, you also have patients that have some neuropathy. Some of these patients are going to be smokers. So A1Cs are not always the best. You know that they're not always going to be controlled. So this is a patient who I told, I put her in a post-operative shoe, works, don't get the dressing wet, and went home and took a shower. This same patient who had, bilateral HIPJ ulcers, I did it on her other side, and she developed a new ulcer on one of the sesamoids. I went back in, took out the sesamoids, and then she came back in 3 weeks later with the septic MPJ. So had to go back in again, take out the MPJ, put in the cement spacer, and then she went out to fully heal. So it's all the same complications that you would expect from regular Kellers, from just performing Kellers for either bunions or hallux limitus hallux rigidus. plus everything you would expect to see from diabetics. Now, when is a good time to perform the Keller, and when's a good time to perform the hallux arthroplasty? As you saw, and again, I'll mention it again, the Keller does not address osteo at the level of the HIPJ. The HIPJ arthroplasty will. So that's number one. So where patients have, so if a patient should have osteo with the HIPJ, I'm more inclined to do that. But again, that's not always what I'm doing. Sometimes I'll just bone biopsy it and then treat the patients with orals or PICC lines, depending on the sensitivities of the bug. And the other thing is that if there's a hammered hallux, those patients will probably benefit more from a hallux arthroplasty than from a Keller bunionectomy, than from a Keller arthroplasty. Just because patients have an ulcer at the HIPJ does not necessarily mean that they must have a Keller. This was a patient who had been admitted with an A1C of 14, and she was having she was admitted for, I think this one with her gallbladder or pancreas, I think pancreatitis. She was admitted for pancreatitis. So obviously I'm not going to operate on her, at that time. So did a couple of months of local wound care, cam boots, surgical shoes, the works. After a couple of months of this thing not getting better and her, managing her blood sugars and getting down her A1C from 14 to something more reasonable, say, in the level of the 8-9s, I got an MRI on her, and she had a very large EHL sesamoid. So what I did for this one is I performed a hallux arthroplasty and took out the sesamoid dorsally. I didn't do like the standard medial approach on this one. I did a hallux arthroplasty, took out that sesamoid, and pinned it. And this patient again has remained ulcer-free since. And and the third digit that had the ulcer healed with just local wound care. I didn't have to do anything for that. Now, the other option is this thing called the medial band plantar fasciotomy. This is described and talked about by Haewon Chu. He has this Instagram page. I love looking at. He calls his handle is limb salvage surgeon. He's based out of New Mexico, so he does incredible work. Now, with the medial band plantar fasciotomy, you're using an 18 gauge needle on the side of the foot, and you're releasing the medial band of the plantar fascia. I have not done these. I've not attempted this yet. One of the people I work with has a lecture on present podiatry, showing highlighting some of the cases that he's done. His name is Dr. Yaeger. So if you get a chance, that's worth watching. And you can see some of his cases. Again, I myself have no experience with this. I don't necessarily know when to perform this versus the Keller. My go-to has been the Keller, and my patients have done relatively well. Again, I have one recurrence. One of my other patients developed a second digit hammer toe, and they were developing a trophic lesion at the distal tip of the toe. So I was able to manage that with a flexotomy, and that was that. So the other thing that I think bears talking about is, so how far can we push the envelope and how far should we push the envelope? This is one of my patients at one of my hospitals. He has a right lower extremity BKA. The guy's a vasculopath, and this is his hallux. So again, like I mentioned before, classic story, opens and closes, going to the surgical shoe and it closes, goes then back to his regular work shoes because he actually works as a security guard in a federal building, and it opens up and it goes back into his shoe. Now, this is what his foot looks like. Now, we can all imagine what the causal pathway is over here. Like, we know that his ankle doesn't get a whole lot of range of motion. We know that his first TMT is elevated. We know that he has a first rail of os, and we know that his hallux is all the way down and it's rubbing it. You can see it right there. So we know why he's getting this. Now, the question is this somebody that would benefit from like a rear foot fusion? Is this somebody that needs like a tibial-talocalcaneal arthrodesis? Or is this somebody where we can do a 35 to 45 minute Keller and get this thing healed that way? The other option is, should we just tell him, look, you already have a right BKA. You don't have the greatest blood flow here. I tried referring him out to my vascular interventionist. He's never made the trip over there. So I'm not going to intervene on him unless he gets revascularized first. But the question is, with a foot like that, is this somebody that needs something done at the rear foot, or is this somebody that, well, if this is his biggest problem, try the Keller and see how that goes. So I have not intervened on him yet. I'm hoping to not to. I'm hoping that, with just shoe gear modifications alone or an AFO, we'll be able to manage this. Time will tell. Now, not every HIPJ ulcer needs a Keller. This patient was diagnosed with an atypical ulcer and had been there for years, and you really can't explain this one. Now, at one point he was an uncontrolled diabetic. At one point his A1C was somewhere between 12 and 14, but he also has HIV. So this was biopsied and it came back as Kaposi sarcoma. So you can do all the Kellers in the world and this thing is not going to go away. This patient is currently scheduled for surgical excision. I'm working him up in conjunction with hemonc and derm. At the moment, he also has stable metastases to his ribs. So I'm going back and forth with his dermatologist and the oncologist going, look, is there really a rationale to remove this thing when he already has, stable mets to his ribs? So we're going back and forth about whether, yes, I should remove it, should not remove it. But the point for this discussion is not every ulcer needs a Keller. Not every ulcer, quotation marks, is an actual ulcer. Again, this Kaposi sarcoma, a Keller is not going to address this. So some pearls. It's a good procedure for healing HIPJ ulcerations. It's not the only available procedure. There's hallux arthroplasty. Again, if the patient has a hammered hallux and the lesion is more distal, you're probably better off performing the hallux arthroplasty. There's also that medial band plantar fasciotomy. I don't have any experience with it, but there's papers on it. It's well described. You have to be careful with the amount of bone that you're removing. You do not want to get one of those hammered halluxes or one of these super unstable halluxes that I've shown pictures of. The Keller is not without its own inherent risks. Plus, over here you're operating on patients with diabetes and whatever and their complications. So again, recurrence, infections, worsening deformity. Again, all these are inherent to the Keller itself. Plus, you also have the fact that you're operating on diabetics now. If the patients have osteo and you're performing the Keller, you still need to treat the osteomyelitis. Either perform the hallux arthroplasty or perform a bone biopsy, depending on the given situation. When you do these, you still need biomechanical control following surgery. It is not enough to just perform the Keller and then go back into your whatever junky slippers you were wearing beforehand. They still need biomechanical control following surgery. Questions, comments? This is my cell number and this is my email. Thank you all for your time and attention.